This program was made possible in part with generous support from Gordon G. Lund.
Hello and welcome. We have a very important topic today. We're going to be talking about end-of-life resources. And with me are two people who are the perfect guests for this topic, talking to two physicians. I'll introduce you to them in a minute. As many of you in Minnesota know, we are right in the thick of our legislative session, and we're taping this on April 3rd, 2023. So things may shift quite a bit in the next few months, or when you actually view this show. Well, this is a topic that it's kind of hard for me to talk about. I think most of us have some qualms about thinking hard about the reality of not living forever. And we're going to talk tonight about some of the choices that people have and some of the shifts we're seeing in the medical world and in the public view also. So I'll introduce you. Our first guest is Rebecca Thoman. She is a physician who went to the U of Minnesota, specialized in family practice and community health. And your community health is very strong right now in terms of your work. You've worked hard as a policy influencer physician, right? For 2 decades, Rebecca?
Yes, I've been in the world of public health and healthcare policy for several decades, taking my experience and my training in medicine and bringing the voice of professionals into the policy arena, because I really believe that we need people who understand how the laws have an impact on the ground level in order to influence and come out with good public policies that work for people.
And you've been involved in some of our really hot issues in our country and in our state. Gun control. Tell me some of the
control,
others. Right.
Healthcare access. And funding for the NIH for cancer research.
That's right.
Is involved in preventing children from using indoor tanning facilities to reduce melanoma rates, and now end of life.
Did anything lead you to end of life that was a personal driver as well as a professional one?
Well, you know, in my medical training, I did see a lot of suffering at the end of life. Both my parents died. My mother had a stroke and then lived for quite a while afterwards. My father died of esophageal cancer. He lived for 4 months after his diagnosis. And so just having seen those experiences, there is a sense of my own, you know, I want this. I want options at the end of life. So there's some self-interest in this for me. But, you know, I've seen the suffering, and it seems to me that medicine can do better. We have ways to help people avoid that kind of suffering at the end, and so that's what has inspired me.
Our second guest, I want to introduce you to David Plimpton, who was a gastroenterologist in his career days. You're now retired.
Yes.
You are a volunteer with Compassion and Choices, the organization we'll be telling you a lot about.
Yes.
And did you also have a personal and a professional motive kind of for getting this
I did,
involved?
very, very much so. And in 1980, my father, who was a retired surgeon, joined Hemlock Society, which was one of the early groups trying to raise consciousness about
Right,
1980,
right?
1980, about controlling the amount of time one takes to die. And he had Parkinson's disease, diagnosed 4 years before that. He had in his mind planned to sequester seconal, a barbiturate, which was available at the time. And he talked to me on several occasions about this over the next few years. His goal, he said, was to live as he wanted to live, as how he identified his life, and that he wanted to avoid several bad years that he knew were coming because of the Parkinson's disease. His father also died of Parkinson's.
He did.
And so as the disease progressed, he unfortunately developed dementia, and he lost the concept of medical aid in dying. And he ended up in a nursing home for 3 years and died from untreated bacterial pneumonia, which is a standard way that...
So a hard 3 years, I
yes,
bet.
right.
Yeah. I'm guessing most physicians are very supportive of medical aid to dying folks, aren't they?
Well, we have some evidence for that through the Minnesota Medical
studies.
Association. In 2016, a survey was done regarding favorability or non-favorability for medical aid in dying. And 59% of physicians said that they favored its being available.
59?
59%. They didn't say that they would necessarily want to be involved, but at least it should be available. 12% said they were uncertain and needed more information, and only 29% were opposed.
That still surprises me that that many are opposed when you work as a physician so intimately with end of life so often. Well, Compassionate Choices is the organization that you both are excited about and very involved. You're the managing director of the organization. If you're seated on a plane and someone says, what are you putting your efforts into right now, how do you explain this to the person next to you?
Well, what I say is that my work is to bring an Oregon-style death with dignity law to Minnesota. People tend to think of it as death with dignity. The actual practice itself is called medical aid in dying, and it's a very specific clinical practice. They've been doing it in Oregon for 24 years, and now 10 states also have authorized the practice. But it's a very specific medical practice where a patient is terminally ill with a 6-month or less prognosis, has full decision-making capacity so they can make their own healthcare decisions, they can give informed consent, and then they have the ability to ingest medication. And they can ask for, go through a number of steps, and then if they qualify, they can receive a medication that they can self-ingest at the time that they choose. And it's really very patient-directed, patient-driven. It's them deciding that they may not want to go through the final weeks or months of a predictable death. And so the people who tend to use it the most around the country are people with late-stage cancers or neurodegenerative disorders like ALS.
Or Parkinson's.
People
right.
who have their cognitive capacity but have tremendous suffering.
But there are some limits then, aren't there? I mean, if you are not dying, but you have what you would call intractable, horrible, horrible pain, that doesn't qualify you.
That's correct. Not for medical aid in dying. There are other options for people.
There are other options, and we'll talk some
but
about
not,
those.
But not medical aid in dying.
Also people then, as you said, who are people with advanced dementia could not
Correct.
have medical aid either, right?
That's right. You have to have mental capacity at the time you make the request and at the time that you ingest the medication.
And you have to be 18, is that correct?
Yes, you have to
That's
be an adult.
another-
That's right.
The people that are adamantly opposed to this, What do you hear they are fearing if this legislation passes here in Minnesota or any of the other 40 states that don't have it yet?
Yeah.
You know, it's the same arguments that we have heard since the 1980s. The first law passed in 97, and the concerns that we hear now are the same ones we heard then, but they've not borne out. I would say a lot of the opposition comes from misinformation or misunderstanding about it. Using the term, this is assisting a suicide. Well, I'm not for assisting a suicide either, so that's not what this is, but I think using that kind of terminology misleads people into thinking this is something that it's not. So misinformation is a big part of it. Fears from communities that I would describe as having had to fight for their health care rights, particularly the disability community or some minority communities. There's a sense from some of them, a historical mistrust of the medical system. And so there are some fears that there would be abuse, or families would be abusive, or insurance companies would force them. And none of this has come to pass. And so the fears are, I think it's easy to scare people into being opposed. What do you see, Dave?
Well, there's this idea of a slippery slope, which is used
Yes.
in many, many arguments, not just medical aid in dying. But the fear of slippery slope in medical aid in dying has never been realized. There are probably 70 years now of data from states that have enabled this law. And there's no progression to what's called euthanasia, where the physician actually injects the medication into the vein.
That would be a strict definition of
euthanasia. Correct. It's how we treat our pets. That's strictly euthanasia.
The general public in a Gallup poll came out really strongly, didn't they, being for it? Do you remember the numbers, either one of you?
Since 1997, the population between 55 and 68% of U.S. population supports the concept of medical aid in dying. And actually the numbers of physicians mirror that. In national surveys and in state surveys, we found doctors around 58 to 60 to 62% support this as an option, and only about 25% are against it. And then there's that kind of not so sure group.
Yeah, that's so interesting. Well, when people are thinking about this for the first time or early thinking, I'm sure they're wondering, what is it like to die when you have a pill that you take and a doctor supporting that? What is the process of dying like? And can you explain what you've seen?
So the process is also written into the legislation, and it's slightly different from state to state, but the basics are the same, which is that two separate physicians have to evaluate the patient to be sure that they qualify. They have a terminal disease, they have cognitive capacity, and if there's any question about that, then they'll bring in a mental health assessment. But by and large, doctors know when people have capacity and when they don't. But there are some situations where they might want a mental health consultation. And then the patient has to be told all of their alternatives. They need to be offered a referral to hospice, because hospice is the gold standard. We want everybody with a 6-month prognosis at the end of life to be enrolled in hospice, because they will feel better and live longer. So we want to be sure that they have a referral to that if they need it. And then they also have to do some written documentation, sign a form. They have to have 2 separate requests. All of that is documented. And then if they ultimately follow through, what we have found is, of the people who go through the process and get a prescription, only about 2/3 actually go through with ingesting the medication. About another third don't. We don't know why. It could be that they lose capacity. It could be that they just felt they didn't need it, which one of the big advantages of medical aid in dying is that people get a sense of relief and control. And then they can take their dying weeks and months and feel better about it, because they feel their anxiety is reduced.
You
So
know,
it-
when people have choice, that seems to be such a key element in life in general, doesn't it?
And
Very
the
much so
it's not
here.
a pill, and there have been different forms of the medication. Currently, it is a 5-drug compound, and that, you know, you mix that with a liquid and ingest that in a couple minutes. And most people now will go to sleep within 3 to 10 minutes and stop breathing within half an hour to 2 hours. There are some that will live longer and may not die and stop breathing for 10 hours, but that's pretty rare. Now, really, we have it down to a science where most people will die within 2 hours, and it's comfortable. They will fall asleep.
So
and
they're
their
not in
heart will
pain
slow.
when you say
No pain at all.
comfortable.
They'll go to sleep, and then they will just, their breathing will stop, their heart will stop. And it's lovely because families are involved. They may be there at the day of the ingestion. Some make a party environment out of it. So it's really a wonderful alternative for some of the suffering that we know happens, for example, with ovarian cancer, pancreatic cancer.
Your father's kind of death.
That's right.
What if, Rebecca, the families are torn? I can just envision this would not be something that all families could get on board for, or all family members.
Right.
As a physician and also your experience, Dave, how have you worked with the family that's got the two opposing strong feelings about this huge decision?
Yeah. Well, again, the gold standard is patient autonomy, so you refer to the wishes of the individual who's terminally ill and dying. Then if there's conflict among the family members, you negotiate. You say, you know, what is it that you need to allow me to carry out my wishes? You know, and
So the patient says that to the
family. Is there something you need from me that will allow you the comfort to allow me to die?
So autonomy
Yes.
is, I'm hearing,
Right.
super important,
Yeah.
and gets the most weight
Right.
than the person
Yes.
with that decision.
If they can't resolve it, then you would call in the ethics committee, who would then try to negotiate with the family, but so that everybody feels as though their voice has been heard.
Now,
And
the
that's what's
ethics
important.
committee-
Yes.
I know nursing homes have
Yes.
ethics committee, but are you talking about if the person's in the hospital, there would be
Yes.
one also?
Yes. Yes.
Okay.
All hospitals have to have ethics committees for issues just like this.
Yes, of course, I bet they do. And does your organization have any kind of consulting ethics support?
Well, Rebecca, you know about that.
So we do not. Really, medical aid in dying is becoming integrated into the standard of medical care. So we can look to hospices for support. Many hospices will participate after the law is passed. Not all will. But that's a whole multidisciplinary group of professionals that are
Right.
there to support the patient and support the families. And there is spiritual support. So it's a great environment to get that kind of support and reconciliation.
So you are really, it sounds like partnering with hospice programs.
Well, not officially. You know, we really work on passing the legislation and helping them, for example, develop a policy within their
Okay.
institution and help training the individuals there, the social workers, the nurses, the physicians, on how this works. We have experience now from 10 states. Hundreds of physicians have participated. And so, you know, it's the way any doctor learns something new. They learn it through professional associations, through mentoring, through research and publications, and that's what would happen then in that state as well.
Some of the other states, I remember Montana, which kind of surprised me. Hawaii. What are a couple of the others?
So they're Oregon, Washington, and Montana was actually by a court ruling, so they don't have a prescribed law the way the other states do. And then Vermont was the first state to pass it through its legislature in 2013.
Way back.
Yes. And then
Interesting.
California was really the tipping point, I think, because the very famous story of the young woman, Brittany Menard,
Yes.
who was in California and moved to Oregon. She had a brain tumor.
Very young and very beautiful.
Very
and-
lovely. She was on the cover of People magazine.
That's right.
And I really think that launched a sea change. And since 2015, California passed the law, and then they started going one after another. So Colorado, Washington, D.C., Hawaii, New Jersey, Maine, and most recently, New Mexico.
Wow. And now, just recently, too, I believe Oregon passed the legislation that allows people who are not residing there for a set amount of time to go and die there. Am I correct?
Well, there was a lawsuit brought because the belief, it was actually brought by a physician who lives and practices right on the border between Washington and Oregon. And his patients, who he cared for, from Washington state, he could not help them
Oh.
the way he could an Oregon patient. And so it was about doctors treating patients differently based on where they live, and felt that that was unconstitutional. So that lawsuit actually resulted in a settlement, but then the state is also decided to eliminate that residency requirement because of that ruling. And the same lawsuit is playing out in Vermont. And so future iterations of the bill, such as Mexico, don't have that state residency requirement in it. However, it's very difficult for people to travel at the end of life.
Yes.
So the idea that we would move somewhere, I mean, you'd have to move somewhere well in advance because you don't want to leave your family, you don't want to leave your care team,
Your family maybe could not travel.
and only
Yeah.
people with resources. Is that an option? And then, you know, if you do go to another state, you can't go back home and ingest the medication because it's not legal there. So, for example, if you went to Oregon, you'd have to stay in Oregon to ingest the
So
medication
this is
as
an
well.
important piece, isn't it?
Yes. Even though that law has been struck down, it's not leading to a huge influx of patients as far as we know. I'm sure that more people will be able to travel there now. But frankly, the residency requirement was pretty minimal. I mean, you just had to have evidence that you lived in the state. So that wasn't a huge barrier, but I think that also has implications for just the idea of trying to constrain healthcare across state boundaries.
That's a whole nother show, isn't it?
Yes, it is.
Excuse me. VSED, another resource. We've only got about 5 minutes left, so we need to move here. But would one of you explain what that is and some of the differences?
Sure, I can explain it, and then I'll let David talk about the clinical experience of it. So VSED is an acronym that stands for Voluntarily Stopping Eating and Drinking. And it's exactly what it sounds like. An individual decides they're just going to stop all intake and they will die by dehydration in about 7 to 10 days. It's an alternative for people who don't have access to medical aid in dying. A person, again, has to have volition, and with a good plan and a strong medical support team, it's not uncomfortable for the patient. They are kept comfortable. It's difficult sometimes for the family, but VSED is legal in every state as long as the patient is at a point where they have volition and can make their own choices.
Do you need a doctor's okay for it?
You don't need their approval for it, but the reality is you do need a medical team supporting you, because it would be inhumane to try to go through dehydration with no medical support. So I'm sure David can explain that.
Yeah.
Yes. I actually, since I retired, have had the chance to help 2 old dear friends go through VSED. And the person I'm thinking about was 86 years old and had a remarkably fulfilling and fulfilled life, developed esophageal cancer, the squamous cell cancer, which tends to have a little better survival rate than the than the esophageal cancer that actually begins in the stomach. She had some radiation treatment, had decided she would not have surgery, but with the radiation treatment, it became too painful to eat. And so she decided that she was going to stop eating and drinking. And and once you decide that, in a sense, and you're committed to it, and you've demonstrated that you could go several days, you are terminally ill. So you can then get hospice involved. And she had a relatively short course, initially full consciousness and awareness, then a mild confusion, and then some delirium, and then coma.
So again, a
Yes.
fairly peaceful.
Yes, and
death,
with
as we would
that, you
say.
can use the morphine, you can use the anti-anxiety medications.
Well, this is a topic that we might have to revisit and have you back sometime. So much important information. We've got some resources. And first, would one of you give your website, because that's a key
Sure.
resource?
CompassionandChoices.org, and we have lots of information on VSET. We have a Minnesota page that talks about the legislation, which is called the End of Life Option Act. And we also have lots of information about advanced care planning.
So, Compassion and Choices, and you've got the, not
Not
spelled
the
out
ampersand, the
Right.
A-N-D,
A-N-D,
Compassion and
Okay,
Choices.org.
And then 2 books, and you gave some really interesting titles to me that we'll put up real quickly.
Well, the first one is by Barbara Coombs Lee, who was one of the original authors of the Oregon Bill and was the CEO and president of Compassion and Choices for many years. And it's called Finish Strong. And it's now in a 2nd edition, and it's tremendously informative.
Finish Strong.
Yes.
And then the next book is one you've probably heard about. It's
Well, the next one is just a general book about grief, and I don't think in all English literature there's a better representation of grief than C.S. Lewis's A Grief Observed, which he wrote after the death of his young wife.
Yeah, it's a great book. Well, thank you both so much for coming down and explaining and teaching and sharing. It's been really an important interview. So
Thanks for the
Well,
opportunity to
thank
talk
you.
about this
You're
important
very
issue.
welcome.
We're
Thank you.
so grateful to be able to talk about this.
Well, we need to talk more, don't we, as a
Yes.
society, as a community. Thank you for being with us. I'll be back again next week. Until then, have a good week and start thinking and talking about this big topic if you can with your family. See you next week.